We might. I think we might give it a... What do you think, Greg? Shall we get started, I guess? I think.
Let's give it a go.
Yeah. I'll stop sharing my screen because I wanted to just look at my notes. So I wanted to just bear with me while I'm going to actually read some of my notes, because it's the first time we're launching our webinar series. Very big hello to everyone. My name is Moira Junger, and I'm the CEO of the Sleep Health Foundation, and I'm a long-standing practicing health psychologist with a special interest in sleep. So I'd like to welcome you all today and thank you for attending. And the Sleep Health Foundation acknowledges and pays respect to the past, present and future traditional custodians and elders of this nation, and the continuation of cultural, spiritual and educational practices of Aboriginal and Torres Strait Islander peoples. I'm joining you today from Wurundjeri country of the people of the Kulin Nation, and I pay my respects to any First Nations people joining us tonight on the webinar. Well, this is Sleep Week, and it's the first time that we're calling it our own Sleep Week here in Australia. It will now firmly be planted in late September calendars in the week leading up to the clocks going forward for daylight savings beginning. So a little bit about us and our mission. The Sleep Health Foundation is a not-for-profit health promotion charity that was established around 2010. We're a community-facing organisation, and that's why we're launching this series of monthly free webinars for all of the community to access. We'll have different topics every month. Late October, we'll have a panel of people with lived experience of sleep disorders speaking about their road to diagnosis and associated challenges. And in late November, we'll have Professor Peter Sestuli from the University of Sydney talking to us about the future of sleep. We know that sleep is an essential pillar of health. We consider it the foundational pillar here at the Sleep Health Foundation. If we don't sleep well, we're at risk of development of chronic health conditions, obesity, cardiovascular disease, type 2 diabetes, some dementias, cognitive decline, and also, of course, mental health conditions. If we do sleep well, we can help to preserve good health and less morbidity and mortality. So even though we all agree that sleep is an important part of our well-being, it receives very little attention in terms of policy, curriculum in schools, indeed even curriculum within healthcare professionals. So 3 days ago, even The Lancet, which is a prestigious medical journal, it published an editorial on the importance of sleep. And I quote, "Sleep disorders are an underappreciated public health problem. They are common, cause much distress, and have far-reaching consequences on population health and economic well-being." So despite the title of tonight's webinar, Physical and Mental Health, we're focusing mostly on mental health, although I threw the physical health in there to tap into Greg's in-depth knowledge of our circadian system, and I hope to touch on daylight savings later in the webinar. So now to introduce Professor Greg Murray. Really appreciate Greg giving up his time and talking to us tonight. Professor Greg Murray is a director of the Centre for Mental Health at Swinburne University of Technology here in Melbourne, Australia. He conducts research into mood disorders, circadian rhythms and personality. He's ranked in the top 1% of researchers worldwide in each of these fields and is recognised as a world expert in bipolar disorder. Professor Murray has published extensively on the chronobiology of mental health. His public engagement includes being chair of the Sleep Health Foundation Daylight Savings Working Party, frequent school talks on sleep health, and he has a regular mental health segment on ABC Radio National. So Greg and I have met a few times to plan this event and talk about our preferences for how we're going to run it. So we've decided on a professional yet relaxed conversational style rather than lectures with a lecture style with slides. So be sure to let us know afterwards your feedback. I think Greg's a very good storyteller. I love stories. I love talking. So let's begin now. Welcome, Greg. And
thank you, Moira. It's lovely to be invited to do this, and great to speak to you. I'm a great admirer of your expertise as a clinician in this area. So if I get stuck, I know I can throw the question back at you.
Fantastic. Well, my first question, and a really genuine from the heart, is just what interests you about sleep and mental health, and how did you even get into this field?
Yeah. I've always been interested in mental health. I have a family history of serious mood disorders, so I've always been interested in that. And then while I was doing my master's in clinical psychology at La Trobe Uni, sometime in about the 1700s, Stuart Armstrong, who is a circadian and sleep researcher, works mainly with animals, came and gave us one lecture on the circadian system. And he told a story about this idea that the circadian system is kind of like a rhythm, a 24-hour rhythm that pulses away in every organism, including humans. And if there's any disturbance in that system, then all sorts of psychological and behavioural disturbances follow. And this story spoke very deeply to me because at that time I was transitioning from being a full-time musician to being a clinician and an academic in psychology. So I've been a drummer since I was 6.
Wow.
So this metaphor that Stuart introduced, that there's something fundamental about a 24-hour rhythm that is fundamental to mental health and physical health. I just found that incredibly interesting and appealing. Yeah. And it remains a really important part of the way I think about mental health. My specialisation in mental health, as you mentioned, is mood disorders and particularly bipolar disorder. And those disorders actually are characterised, unlike, say, anxiety disorders, they're characterised by the fact that they cross days, right? Yeah. So you can have an anxiety attack or a phobic response to something. The time frame of that is seconds and minutes. The time frame of mood disorders is days and weeks. And so that's kind of how I think about mental health, is very much through that lens of patterns across time and rhythms across the 24-hour day. So yeah, that's where my interest started from.
Wow, because that's actually leads on perfectly to because I think we need to unpack at the start of this conversation, like because to understand that relationship between sleep and mental health, you need to tell us more. But can you tell us in really simple terms, what is the circadian system?
Oh, that's my favourite question of all. I could still be talking in 2 hours. So
I'll put a timer on.
So the circadian system is a strongly conserved biological system in just about every living species on the planet Earth, just about every species, from your cat to your rosebush to yourself, to creatures who see very little light deep in the depths of the oceans. Just about every species that we know of runs a body clock or a circadian system. And the reason evolution latched onto this and hasn't changed the system very much over time is that it just so happens that the planet we live on, evolution is designed to make sure we optimize our engagement with the environment, right?
Yeah.
But the Earth has 2 environments, dark and light. And evolution decided way back in, millennia ago, that change between light and dark was so important that it couldn't be reacted to, it had to be predicted. And it is. Still today, we as humans, for example, measurably start the process. The most vivid example, I think, of the circadian system in the human case is the fact that we start to wake up from about 3 o'clock in the morning. If we're sleeping well, from about 3 o'clock in the morning, we start to wake up. And that waking up process is endogenously driven. It's driven from the inside by the circadian system, which is keeping track of time and predicting when the sun is going to get up, because that's when humans function best in the environment, is when it's daylight. Of course, some species it's the opposite, but humans function best in the daylight. So we are being woken up every morning by a body clock inside us. I think the general public doesn't quite appreciate that. I think the general public thinks we are waking up because, you know, we heard the guy picking up the rubbish bins, or the guy next door heads off to work in the bakery, or we're starting to sense the sun coming up, or the birds are singing. Those things will wake us up, but even in the complete absence of time cues, the circadian system wakes us up. In human beings, the circadian system is located deep in the brain, deep in from where I'm pointing, about that far in.
Yeah.
And in a tiny little set of the master, what they call the master oscillator, it is located in the bottom of the hypothalamus, deep in there, in a tiny little set of cells. And that master oscillator then drives timing of all cells in the body, all physiological processes, and all behaviour, with the behaviour being most obviously the 24-hour sleep-wake cycle. In fact, a mate of mine who I met through this daylight saving working group that you guys invited me to chair, a guy called Russell Foster from Oxford, who's a bigwig in this area.
Yeah.
He says all biology is circadian biology. That's just the way biology works. It is all timed, and the fundamental timing pattern is the 24-hour cycle.
Yeah.
And the sleep-wake cycle sits on top of that. So the time at which we want to go to sleep, and as I already said, the time that we wake up, is determined by the circadian system. So that's just an intro. I've got millions of other things to say.
Well, I suppose, I mean, that's super relevant to all of us, and especially, I mean, some of the people on this webinar would be health professionals, but a lot of people would not have heard that before. That's, you know, it's new to them, and it's so important for us to just keep talking about this stuff in fairly plain language, for people, because if you're having difficulty with sleep, for instance, one of the most important things is to understand why. And not do a band-aid approach. Like, say it's like a sleeping pill, for instance. They do have their place here and there, you know, short-term and intermittent, etc. But you know, I would always want to talk to people about, what do you think is going on? Let's have a good assessment of what's going wrong with your sleep. Let's look at the causation if we can. So I think in terms of that circadian fate, like, can we talk about it in action, like in practical terms, around probably where it first is most important, where it first becomes more of that we see clinically, for instance, where it starts to wreak havoc a little bit when it's disrupted, is perhaps a story around the adolescent sleep deprivation. If you could have a few words, a few thoughts on that. Yeah,
this is what I give 2 or 3 talks a year to different schools on exactly this topic, and it's what I think the American Sleep Association calls the epidemic of adolescent sleep deprivation.
Yeah.
And you can't explain it without understanding that there is this body clock.
Yeah.
So in fact, just take one quick step back.
Yeah.
And you'll know this, but I think it's a useful little idea, that there are 3 factors that determine when we are likely to fall asleep. And the first 2 of them are well known to the general public. The first is what's called a homeostatic process. So it's like hunger. The longer that I have been awake, the more likely I am to sleep. That makes perfect sense, exactly like hunger. The longer since I've eaten, the more hungry I am, and the more likely I am to enjoy food. A process like that. That's number 1. Number 2, that the public is also very well aware of, is that we can disturb sleep with stress or arousal. So if we're anxious about something, if we've got to get up for an early flight the next day, famously, we'll find it very hard to get to sleep. It's reliable, isn't it?
Yeah.
If you have to get up early, it's very difficult to get to sleep. But the third determinant of when we are ready to go to sleep is whether our body clock is ready for us to go to sleep, right?
Absolutely.
And so, you know, we've seen this in action. And to go back to travel again, we see this with jet lag, don't we? That, you know, you can travel all the way to, you know, New York and be exhausted from the hours and hours of faffing around at airports and not sleeping on the plane, and you're terribly exhausted, and you finally get to the hotel in New York, and it feels like you've been away for days, but it's probably only a bit more than a day. and you get into bed because it's 2 o'clock in New York, but you are wide awake because your body clock is still in Melbourne, right? Yeah. So that's how the body clock, you just mentioned, phase, the timing of the body clock, how that impacts sleep. The epidemic of adolescent sleep deprivation is largely caused by the fact that when we hit puberty, we have no decrease or a very small decrease in the amount of sleep we need. And I think, again, this is something maybe the general public, parents are perhaps not fully aware of, that 13, 14-year-olds roughly need as much sleep as they did when they were 11 and 12. There's no decrease in the amount of sleep they need, but their preferred time of getting that sleep shifts significantly later. So whereas the grade 6 kid might be ready to go to bed at 9:30, 10, the year 8, year 9 kid is ready to go to bed at 11, 11:30, 12. There's been a phase shift. The circadian clock shifts with adolescence. Now, that would be okay, and in fact is okay, on school holidays, when the whole thing just shifts. So
they can sleep in and you can get the adequate amount of sleep.
Correct. So you still get the adequate amount of sleep. It's just happening later. The whole thing is phase delayed, is the phrase we use. But of course, that's not what happens during school term, where, if anything, kids are getting up earlier than they did for primary school because people are travelling further often for secondary school. There are activities that are, run before school. So you get getting squeezed on both ends. And so we did a study in Australia, which a student of mine, Dr. Suzanne Warner, did a study in Australia that replicated findings from all over the world. It's one of the most strongly replicated findings that I've ever met, about the amount of sleep deprivation the average secondary school student gets. And we found very, very consistent with studies elsewhere that it was about 77 minutes a night for every night that they had to get up and go to school the next day. So that's Sunday night, Monday night, Tuesday night, Wednesday night, Thursday night, 5 nights in the week. They were getting 77 minutes less than they got on vacation time. And exactly 77 minutes less per night than the American Sleep Association recommends the average adolescent gets. This is a huge sleep debt, which of course, so it's 5 times 77, that's a lot of sleep debt.
A lot of hours,
which of course they try and deal with by huge sleep-ins on the weekend. And which makes perfect sense, and their body wants it. But that causes a bit of problem come Sunday night, because they've actually gone back to a preferred sleep schedule. It's what their body wants to do, and they do it for a day or two, but then bang, it's Sunday night and they have to get up on Monday morning. And when I give these school talks, there's always teachers in the room when I'm giving the talks. And when I point out that Monday mornings must be not really worth trying to teach anything, and all the teachers are nodding, saying, you just can't get information into them on Monday mornings. And that's because you and I, Maura, would say they're probably still half asleep.
Yeah, they probably are. They're probably in REM. So, I mean, we could, I wonder, because that's the thing, I suppose, people would say, and even people listening say, oh, quickly, can you get to the sleep tips? Or, tell us how to sleep better. How do we get more of it? But I guess there's the story unfolding, and the stories, with this idea of, the circadian system, but I guess, I would love to hear you, because I've heard you talk before, saying that sleep and wake are opposite sides of the same coin. And I tend to agree. Can you expand on that a little bit further?
Yeah, thank you. In fact, I've used that phrase for a long time to really capture the fact that good quality sleep emerges partly from how we act when the sun is up. And in fact, I was just reading something. There's been a big review, you mentioned that Lancet article.
Mm.
The importance of sleep in mental health is really being globally recognised, progressively over the last just 4 or 5 years, it feels to me. I mean, people like you and I have been in this industry forever, but just in the last 4 or 5 years, some very major international position statements are coming out about this.
Mm.
And so this idea that sleep and wake are opposite sides of the same coin is now being talked about a lot. And in fact, the phrase that the Wellcome Trust, who are just funding a very, very large set of research studies into this whole topic, they use the phrase, sleep is a 24-hour phenomenon.
Mm.
And obviously from what I said before about the circadian system and how there's this pattern across time, across a full 24 hours. And the way I think about it is that humans are actually adapted to engage with the environment in the daytime and to withdraw into sleep at night. And the more strongly you engage with the environment in the daytime, the more prepared you are, the more sort of primed you are to withdraw into sleep at night.
Yeah.
The first time I noticed this was one of the early bits of research that I did into this whole area was we measured various aspects of physiological and behavioural function across 2 weeks amongst 2 groups of people. And one group of people based on self-report measures of personality and other things, one was at very low risk for depression and the other was at very high risk for depression. Neither of them had depression, neither of these groups. They were university students. But in the group that were at high risk for depression, what we saw on core body temperature, levels of activity, and a couple of other measures was this flattening of the 24-hour rhythm. So that, for example, people who were at high risk for depression were more active overnight and less active in the daytime. So there was this flattening of the pattern, if you think of it as a sine curve.
Yeah.
People who were resilient and, really didn't look like they were ever going to get depression had this really what we call a high amplitude, a big difference between their peak in the daytime and their trough overnight. Think of activity as the most easy one to think about. Whereas those who we knew from what they told us were vulnerable to depression, they had this flattening. They were less active in the daytime and more active at night. There wasn't what I call a very healthy sort of contrast, or what the drummer in me calls a deep pocket, a really strong groove that enables people to make choices and lead a good quality life. So you've got this general idea that lots of engagement in the daytime actually primes you to be ready to sleep at night. In fact, there's this really interesting study. It's just one study, so we always have to be careful about this, but in adolescence, and I always mention this when I'm speaking to schools, a very nice study that showed that the more that adolescents were engaged in what they called their passions, could be sport, could be music, could be their friends, could be whatever, but the more that adolescents were engaged with their passions in the daytime, the better they slept. And in fact, this idea connects up with something that all clinical psychs and health psychs are very familiar with, and that's cognitive behavioural therapy for insomnia, where the cognitive behavioural therapy for insomnia tells us that one of the things that we really can do that has an impact on the quality of our sleep at night is to get outside in the daytime, preferably early in the morning, get some sunlight in our eyes, because the body clock wants to know whether the sun's up or not. It likes to have that confirmed by outdoor light. There's not enough light in most indoor settings to do this work. It has to be outdoors. just a little thing there. There's a little trick that's to do with vision, where at the moment I'm under a lamp and to my eyes, it looks pretty bright. But that's a trick to do with the adjustment that my eyes are doing to do with the level of light. It's hard for us to perceive, but outdoor light is always orders of magnitude brighter than any light we get inside. So when we talk about engaging with the world in the daytime, we really do mean there's something very important about it outdoors, which is why, for example, some schools are swapping out their maths and physics and history lessons on Monday mornings and moving sport to Monday mornings.
Yeah, get them out in the light.
Yeah, exactly. So this thing about sort of energetic engagement with the day is sort of counterintuitively, I think, one of the things we can do to improve our sleep at night, but it's because of this linking 24-hour rhythm in which sleep sits. Sleep is part of that rhythm.
So it's over and above the light, like so engagement. You're talking about that study with the teenagers and their friends. What if what they love to do was all just sit around with their games inside? Does that still hold true, do you think? Or was it mostly a function of the light?
In that study, they were just self-reporting activities that they were passionate about. My prediction would be, and I don't have data on this, but theoretically, we would expect that the effect would be magnified if they happen to have a passion that put them outside.
Yeah.
These things are going to be multifactorial, aren't they? There's going to be, lots of things going on. So one of the things is about passionate engagement, but another thing is actually about light. Another thing will be about exercise and the timing of food and some of the other things we know about in regularizing and building routines into our day, which is another really important determinant of how well we sleep.
Yeah, that's right. So it's all right. The routines, the light, being engaged in activities. Can you tell us a bit more about this? There's a lot being written and talked about this notion of the mind after midnight.
Yeah.
Can you expand on that?
Yeah. So, I was thinking about this just today. There's so many different links between sleep and mental health. And here's an idea for people to get their heads around. There's so many different links that we need to kind of organize the different types of links. And one way to organise the different types of links is to think about time frames. Sorry, I'm a drummer. I can't help myself.
Yeah.
But we can think about long-term effects of sleep on depression, for example, and we'll talk about that a bit later, that very strong evidence for the long-term effects of poor sleep on the likelihood you're going to get depressed. You can think about short-term effects. And there's lots of evidence, for example, that if I don't sleep well on a particular night, my emotions and moods the next day will be impaired. So that's what I call short-term effects. But there's also immediate effects, and that's where this mind after midnight stuff comes in. So if we were in a room of people right now, I'd say, put up your hand if you've ever woken up at 3 o'clock in the morning. And then I would, and most people would put up their hand, and then I would say, how did you feel? And most people would say, it was not so good, actually, because there's this very particular pattern psychologically of what tends to happen. I'm being a bit flippant about it. Obviously, it doesn't always happen, but there is a strong tendency for people to get into very negative mindsets if they are awake when they would normally be asleep, and also when other people are asleep. And this has been an interest of mine for a long time, because sometimes I don't sleep well, and have had these experiences myself.
Yeah.
And this actually motivated me to write an article for The Conversation, which I mentioned to you before, Maura, because I boast about it whenever I get the chance.
Please boast away.
So I was contacted. Does everyone know The Conversation? It's a sort of online web thing where academics, researchers are asked to break down for the public in their area of expertise, something that's going on. And during the pandemic, there was a big fuss on Twitter about people sleeping badly. And in fact, there's lots of evidence for all sorts of reasons, some of which we've mentioned, why the pandemic did lead to more disturbed sleep. But someone on Twitter started to talk about waking up at 3 o'clock in the morning and catastrophizing. You know that word? That means you start to think about the worst possible outcome, getting very upset about it. And so this is something I've been thinking about for a long time. So I wrote that article for the conversation just off the top of my head, and 1 million people read it. Actually, it's more than 1 million people.
Wow.
And firstly, that's important because I want to boast. And it's the most.
I think about the reach. I think I'm happy for you, but I think, wow, I think about the reach around the world.
Exactly. And more seriously, the point of the article was I thought, if I'm not the only one waking up at 3 o'clock in the morning and feeling really pretty bad, I would like to sort of normalize this and make people feel like they're not alone with it. And so in all seriousness, I did actually find that very satisfying, because I thought potentially 1 million people are a bit less upset about waking up at 3 o'clock in the morning, because obviously in the article I said it's understandable that we do that because there's biological processes that predispose us to wake up around then. So in particular, I mentioned before that the circadian system starts to wake us up from about then. And you might think, why 3 o'clock? That's a long time to get you out of bed.
Time before sunrise.
Exactly. And there are lots of processes to start off. It's kind of, I think of it like launching a rocket. You know, like they have a countdown on a rocket. There's so many systems that need to be activated, and they need to be activated in the right order. It's exactly the same with a complex system like a human being. To get you ready to get out of bed, especially on a cold winter's morning, does involve a sequence of things. And there is like a countdown that starts and progressively gets us ready to move and get out of bed. So that's one of the things that is starting to happen from about 3 o'clock in the morning. Cortisol starts to rise, an arousal hormone. And by that time of night, melatonin, which many people have heard of, the darkness hormone, it's peaked and it's on its way out of the system. So we've got a bit of a perfect storm of the body being moving from earlier stages of sleep to later stages of sleep, where we're also dreaming more. We may also want to go to the toilet. So there's all sorts of reasons why that, you know, the middle of the night, 3 o'clock in the morning, might be when we do wake up. But then it gets interesting if you accept, and I presume that some of the 33 people on the call do accept from their own experience, that you can get into negative frames of mind when that happens. The question becomes, well, why would you be in a negative frame of mind? Why aren't you thinking about, you know, kittens and
joy,
and joy and dim sims and other things that make life worth living? Why do you go down a negative path? And there's actually a couple of good hypotheses about that. One is, of course, humans are a bit scared of the dark. Very good reason. So being awake at night probably has deep evolutionary significance, association with a startle response and those sorts of things. There's also a pattern whereby overnight, in the dark hours between midnight and dawn, our propensity to positive affect is decreased. There's a circadian rhythm in positive affect, and it's really pretty much gone overnight. It's meant to be gone because positive affect is arousing, so it's meant to be gone. But negative affect does not. There's actually a little pattern where negative affect, if we do measure it overnight by self-report, if we get those measurements, there's a bit of a peak in negative affect at that time. So there's a couple of reasons why you might start down a negative path of thinking. But what's interesting about this mind, and we'll talk about what to do about it in a second, but just to go to this mind after midnight hypothesis. A couple of years ago in the United States, a group of sleep researchers noticed something. They noticed that they were doing research on suicide and sleep. And first they looked at the time of day that suicide is most likely to occur. And suicide is most likely to occur from, 10 o'clock in the morning till 2 o'clock in the afternoon. And I thought, oh, that's interesting, because you might have thought that deep in the middle of the night might be a time when people are, because lots of anecdotal evidence that people feel bad if they're awake at that time of day. And then one of them had the bright idea to say, hang on, but humans are pretty much all awake between 10 and 2, and none of them very few of them are awake between midnight and 6. So if you adjust for how many people are awake across the 24-hour day, if you control for that, then the peak in suicides is drastically between midnight and 6 a.m, right? So if you're awake, which is, of course, the only time you can do that, you can take your life, then it's much more likely that is going to happen between midnight and 6 in this state of mind that we're talking about now. Which reminds me, I just want to say, these topics we're talking about now can be very distressing for people, and I just want to really make it clear that if anything that we say today causes distress, don't sit with it, act on it. And for example, we're talking about suicide very quickly at the moment, and if that triggers anything in you, we would encourage you to call Lifeline and have a chat about it, because it's really important to get that stuff off your chest and not sit with it. So this mind after midnight hypothesis says, what is it about the functioning of the brain that might predispose us to going down unproductive pathways at 3 o'clock in the morning? And in fact, they've pulled together a whole lot of data, which is really consistent with my experience when I wake up at 3 o'clock in the morning, and lots of my clients who I've worked with, whereby when we start to think negative things in the middle of the night, it's very hard to shake them. We can get quite panicky, and that's because our prefrontal cortex, the part of our brain that manages emotions, takes a step back, takes a breath, puts things in perspective, the reasoning part of our brain, it is very impacted by sleep disruption. So it's like we get, the phrase these guys use is hypo, which means under, frontal. So our brain's frontal activity, which is all about control and planning and rational thought, it's really not working very well. And that exposes us to the lower parts of the brain, like the limbic system, and the emotions take charge. And so we can really go round in a bit of a vicious cycle of worry and regret and really, really painful emotions. And that is the phenomenon of mind after midnight. It can really set us up to go down some very unrealistic paths. But what's really striking about it is once you wake up in the morning and the sun is up and you're having your coffee and you're maybe reading the paper and patting the cat, those things you were thinking at 3 o'clock seem silly. They vaporize. There's actually a lovely Michael Leunig cartoon.
Talk about that.
Yeah, exactly this story. Yeah. So that's what's really interesting about it. We know those thoughts are irrational and unbalanced, overly negative, catastrophizing. We know they are, but still it's very, very hard to shake it at 3 o'clock in the morning because of what's going on in the brain and the body and our habits of thinking, which is why it's important to talk about solutions to that sort of stuff.
Yeah, absolutely. So what about, I mean, the evidence, you've told us a bit about the evidence as we've gone through it. It's clear the evidence is unambiguous and it's a strong body of evidence. Do you feel like, is it strong enough? Is there still, like, in terms of if you're presenting to government, for instance, like if you were trying to, or grants that you go for and things like that, do you feel like the message is being well and truly heard?
Yeah.
At a research point of view, I guess.
More and more. The evidence for a relationship between sleep problems and mental health, there is absolute consensus amongst everyone involved in the research. It's also, anecdotally confirmed by clinicians and, lived experience experts, people we work with mental health problems, say the same thing. So everyone is singing from the same page on this. What actually gets complicated, and I was thinking about this as we were preparing for this talk, is how do we just organise the evidence, because there's so much.
Yeah.
There's so much. And so I actually am going to have a quick look at my notes to get the right order of telling this story. So can I just, for a minute?
Yes. Yeah. Oh, do you need to look at your notes? Have you got them ready? Because I can tell.
Yeah.
Okay, go.
So, for starters, the evidence is strongest for depression. The link between sleep problems and mental health problems is strongest for depression. We can also talk about links between sleep problems and just about every mental health problem, but the evidence is strongest for depression. And there are 5 distinct types of evidence that really we've got to, appreciate to sort of be convinced about this. Firstly, you need to remember that sleep disturbance is in fact a symptom of depression. So one of the things that gets a bit complicated scientifically is that one of the recognised symptoms of depression is changes in sleep. And so it's actually part of the syndrome. So in a way you think, well, did it cause it or is it part of it? And both are true. Both those things are true. I know that sounds a bit strange, but sometimes in science when we say, is it that or is it that? The true answer is actually, yeah, it's both. And this is definitely one of those. So sleep problems are part of being depressed. They are intrinsic to it. And in fact, to give you a sense of how prominent sleep problems are, something like 87% of people with a diagnosis of major depressive disorder have significant sleep problems. The sleep problem that is most common is insomnia. And something like 3/4 of people with a diagnosis of depression warrant a diagnosis of insomnia disorder. So they meet criteria for a chronic insomnia problem, which we would diagnose as an insomnia disorder. So the two are strongly connected in nature. And in fact, if we look at the neurobiology of both sleep and depression, they share substrates. They're not separate things. It's not like there's a path in the brain that causes you to sleep and a path in the brain that causes you to be depressed. There are multiple levels in the system, and there are shared pathways that lead to the functioning we call sleep and pathways that lead to the functioning that we call depression. So they're enmeshed, but it is also true that disturbed sleep predisposes to depression. So if you follow people across time and measure at baseline whether or not they have insomnia, the people who have insomnia are and no depression. So no one's got depression at baseline, but the people who have insomnia, if you follow them up 6 months, a year, 2 years later, are 3 times as likely to have a diagnosis of depression than the people who didn't have insomnia at baseline. That's a very, very big effect. Couple of other associations that are clinically important. If someone has a depressive episode and we treat them for it successfully, but they have residual sleep difficulties, they are much more likely to relapse in the future. So sleep is definitely, the sleep part of the picture is something we really need to make sure we've addressed, which is why these days in the diagnostic manuals, the clinicians are reminded, if someone has a mental health problem, also assess for sleep. Don't make the mistake of thinking the sleep will fix itself once the mental health problem is fixed. If there's a problem with sleep and a problem, say, with depression, the clinician has two problems they need to work on. They need to work on the depression and they need to work on the sleep. So that intrinsic connection between the two and the importance of fixing the sleep bit is getting really widely recognised. There's another little twist here. If I have an episode of depression and I have significant sleep problems with it, I won't respond as well to psychological or pharmacological treatments for my depression. Again, showing that there's something really potent about the sleep bit of the problem. And then, oh yes, this is the other thing I want to say. So in terms of, it's really important then to think, okay, so as Greg said, that sleep and depression kind of go together, that sleep problems predict depression. But the consensus is that there is actually a bi-directional association between sleep and depression. So we've been talking about sleep problems causing depression, but it is also true that people who are depressed at baseline are more likely to have an insomnia disorder if we follow them up later. So there's this two-way linkage between depression and sleep problems. In fact, the strongest data on that is some genetic research, which showed, in fact, at the genetic level, having a genetic predisposition to sleep problems predicts having a genetic predisposition to depression and vice versa. So at the genetic level, that two-directional link is observable and quantifiable. And then just one more thing, that the really important thing, and this is what's really changed in the literature. So people have been saying that for a long time, all that stuff that I just said to you, that, you know, there's a deep intertwining of depression and sleep, and it goes both ways. But what's really changed is a couple of very large empirical studies and systematic reviews that have shown, okay, so, and perhaps people in the audience are already thinking about this, so if sleep's so important causally in depression, if you improve sleep, does depression go away? And in fact, that's the new finding. In people who have sleep problems and depression, and remember I said to you that the majority of people with depression have sleep problems with their depression. In that subgroup of people, of course, there are a minority of people with depression who don't have significant sleep problems. We're not talking about them at the moment. The majority of people with depression who do have significant sleep problems, if you treat their insomnia, and insomnia is the most common, not the only, but the most common sleep problem that goes with depression, their insomnia improves and their depression improves. And in fact, one of the, so that's now an accepted, exciting finding, that maybe a new treatment for depression is treating insomnia. And there's a lot of work going on in the field right now on exactly that. How do we best treat the insomnia component of a depression presentation to actually help with the depression symptoms? And there's a whole lot of excitement about that. And in the Medical Journal of Australia just last year, there was a lovely review article about this, speaking to GPs about how they should manage that. You know, someone comes to get help for their depression, the GPs are being encouraged to assess for sleep problems as well. And then if we decide that both problems are present, which one do you treat first? Well, the evidence-based treatments for depression are there, antidepressants, CBT for depression, but the evidence-based treatments for insomnia are also there, cognitive behavioural therapy for insomnia. And so there's a growing discussion about what we call in clinical science the translational significance of this, not just the research showing that it happens, but how do you get clinicians to apply this finding in the real world. So that's what I call a mature finding now, that two-way relationship between depression and sleep, particularly insomnia, with insomnia being what we call a malleable risk factor for depression. It's a risk factor for depression, but you can change it. You can change it with CBT for insomnia. So yeah, it's a really mature set of research, and governments are starting to accept this. Professions are starting to accept this. The other good thing about CBTI, cognitive behavioural therapy for insomnia, of course, is there is still, unfortunately, and shockingly, some stigma around mental health problems, and perhaps less stigma around sleep problems. So we may be able to get better traction with certain patients by offering them a sleep-focused intervention rather than a mental health-focused intervention.
Which is great. So many things we could talk about. And I'm just mindful of getting a few questions in as well, and also getting your thoughts on daylight savings, because this is the build up of sleep week, and the clocks go forward on Saturday night. We lose an hour. In about 3 minutes, what are the health impacts of daylight savings time changing, and how do we best prepare? I mean,
yeah, there's a bit of debate about that, but no, short answer. The acute change into daylight savings time causes, as you say, on average, a loss of 1 hour of sleep. In a population where many people are already sleep deprived, this is not insignificant. And so the acute impacts of that lost hour of sleep, we can see it in a range of health data. Presentations to emergency rooms go up in the week following the change. Heart-related conditions, heart-related events go up in the week after the change. A couple of other things there's sort of more ambiguous evidence about, like car accidents and accidents generally. The pattern of findings is not entirely clear, but on certain indicators, we definitely do see that. And so the important thing for people to really do in terms of preparation is to plan that, we do the change on the weekend, and sort of the government thinks that maybe we'll be better by Monday. But of course we're not. We've on average, obviously it's just an hour, but you average that out across the population of Southeast Australia, where we do have daylight saving. That's a lot of hours lost sleep. So it's really important to plan that on Monday, Tuesday, Wednesday, you're not rushing. So if you're used to, hauling yourself out of the bed and getting into the car first thing Monday morning, getting yourself off to work, just be a little bit careful, because you are, even though your clock might say it's 6 o'clock time to get up, your body clock, the circadian system, is probably still saying it's 5 o'clock, and you've got another hour's sleep to go. And as we know from traffic accident research in transport, being awake at a time when you are habitually asleep is very high risk for micro sleeps and loss of attention and consequently accidents. So I think that being cautious and conscious of that impact, which we can sometimes not be conscious of, is really important. The other thing that people talk about is preparing for that 1 hour lost sleep by trying to set your clock quarter of an hour earlier in the 3 or 4 days before the government says you have to shift your clock. So you're actually progressively waking up a bit earlier rather than doing it all at once, which is what daylight saving requests of us.
Softening the blow somewhat.
Exactly.
Yeah. Yeah, well, I'm just mindful of the time and wanting to keep these to an hour. It's been a fabulous conversation. We probably could do 2 hours easily. I just wanted to have time for a few questions, because I know that there were some people who did put some questions into us beforehand. Thank you for that. And I just wanted to, I think we probably answered quite a lot of them. Like one person, thank you, asked about what time is it best to go to sleep if you're aged in your 50s. I think I would say that Greg answered that by saying it really would depend on your body clock. Like we can't prescribe what time, especially just on not knowing anything about you, what time to go to bed, but to actually encourage you to be really in tune with your own body rhythms. And if you're in your 50s, it'd be pretty similar to when you were in your 30s and 40s, in terms of what time your general propensity for sleepiness and your sleep need would be pretty stable from about 30 through to about 65 or so. So someone else also said, it's interesting, my circadian chronotype is a wolf. I think that we sort of call more like night owls or larks, and somewhere, most of us aren't extreme, where most of us are sort of in the middle of those, being a really early riser or a really late riser. So it's some difficult chronotype given our way our society operates. So I presume, because we are really skewed towards getting up early. So maybe some of the other questions too, we're probably not going to do justice to them. It might be a good idea. I mean, I can probably pledge to write to you. I think people who are registered, I've got your addresses. I can probably write the answers, and in conjunction with Greg, we can talk about that. And then I've noticed on the chat there's quite a few questions as well. Do you want to answer any of them?
Moira, I think I agree with you. We don't want to do injustice to the questions by rushing, and we do have to finish by 7, I know. I would prefer to say 2 things. One, if people have particular questions, I'm happy to answer them by email. So you can find me at Swinburne University of Technology. So they would be general answers. Obviously, I'm not going to speak clinically to anyone, but general responses. But secondly, Moira, you and I could put together some materials, we can bring together some psychoeducation stuff that would be relevant, I think, to all of these questions. And that probably is a more respectful way of handling it than rushing through them.
Yeah, I agree. I absolutely agree. And I just wanted to share my screen again for just a couple of plugs. If we could just have I'll just put this on a full screen. Just wanted to, in the closing moments, thank you so much for attending, and really encourage you to connect with the Sleep Health Foundation. You can see on the screen there, you don't have to become a member, but it'll take you to just put your phone up to the QR code, just take you to our website and have a look at all the stuff we've got. We've got 100 fact sheets on a range of topics. I'd really encourage you to follow us on either Facebook or our other Instagram and LinkedIn and Twitter. And also when you go to the website, there's becoming a member, but also joining up for our newsletter. And you can get on we do a sort of a seasonal 4 times a year at least newsletter, telling you all the things that we're up to. So in closing, just wanted to thank you very much. Round of applause if we were all in the room for Greg. And I notice as people have raised their hands, and there's probably more questions there, which is tricky to, as we said, we're going to get back to you all. So lovely, lots of nice comments in that saying fantastic session and brilliant, and so well done to you, Greg, and thanks so much for coming. I think we can finish on that note. So,
thank you very much, Moira, and thanks everyone for coming. It's been great speaking to you. Would be better if we could see each other. But
I know. One day we'll go back to the hopefully do some in-person town halls as well.
Yeah, that'd be good.
Yeah, great. All right. See you, everyone. Thank you so much. I'll finish the session now. Bye.